Good day. Today we are going to talk about Module 8, a topic mainly on the liver, gallbladder, and extrahepatic biliary system. For the first half of this video, this will mainly focus on the many aspects of the liver, its anatomy, physiology, and various conditions you need to know to understand the inner workings and problems you may encounter with this organ system. This will be a superficial lecture that will cover the must-knows as the topic is actually quite complicated, and due to time constraints, we are unable to cover the nitty-gritty of the hepatic system. So please kindly also use your book as reference. The liver is the largest organ in the body, weighing approximately 1,500 grams. It resides in the right upper abdominal cavity beneath the diaphragm and is protected by the rib cage. It is reddish-brown and is surrounded by a fibrous sheath known as the Gleason's capsule. The liver is held in place by several ligaments. The round ligament is the remnant of the obliterated umbilical vein and enters the left liver hilum at the front edge of the falciform ligament. The falciform ligament separates the left lateral and left medial segments along the umbilical fissure and anchors the liver to the anterior abdominal wall. Deep in the plane between the caudate lobe and the left lateral segment is the fibrous ligamentum venosum, or the Arrantius ligament, which is the obliterated ductus venosus and is covered by the plate of Arrantius. The left and right triangular ligaments secure the two sides of the liver to the diaphragm. Extending from the triangular ligaments anteriorly on the liver are the coronary ligaments. The right coronary ligament also extends from the right undersurface of the liver to the peritoneum overlying the right kidney, thereby anchoring the liver to the right retroperitoneum. The hepatoduodenal ligament is also known as the porta hepatis and contains the common bile duct, the hepatic artery, and the portal vein. From the right side and deep to the porta hepatis is the foramen of Winslow, also known as the epiploic foramen. This passage connects directly to the lesser sac and allows complete vascular inflow control to the liver when the hepatoduodenal ligament is clamped while using a so-called Pringle maneuver. The liver is grossly separated into the right and left lobe by the plane from the gallbladder fossa to the inferior vena cava, known as the Cantis line. The right lobe typically accounts for 60 to 70% of the liver mass, with the left lobe and caudate lobe making up the remainder. The caudate lobe lies to the left and anterior to the IVC and contains three subsegments: the spigal lobe, the paracaval lobe, and the caudate process. The falciform ligament does not separate the right and left lobes, but rather it divides the left lateral segment from the left medial segment. A French surgeon in the 1950s, Quinault, divided the liver into 8 segments, numbering them in a clockwise direction, beginning with the caudate lobe as segment 1. Segments 2 and 3 comprise the left lateral segments, and segment 4 is the left medial segment. Thus, the left lobe is made up of the left lateral, or the Quinault segments 2 and 3, and the left medial segments, which is Quinault segment number 4. Quinault 4 can be subdivided into segment 4A and segment 4B. Segment 4A is cephalad and just below the diaphragm, spanning the segment 8 to the falciform ligament adjacent to the segment 2. Segment 4B is caudate and adjacent to the gallbladder fossa. Many anatomy books also refer to segment 4 as the quadrate lobe. Quadrate lobe is actually an outdated term, and the preferred term is the segment 4 or the left medial segment. Most surgeons, however, still refer to segment 1 as the caudate lobe rather than segment 1. The right lobe is comprised of segments 5, 6, 7, and 8, with segments 5 and 8 making up the right anterior lobe and segments 6 and 7 making up the right posterior lobe. With the venous system, the portal vein is formed by the confluence of the splenic vein and the superior mesenteric vein. The inferior mesenteric vein usually drains into the splenic vein upstream from the confluence. The main portal vein traverses the porta hepatis before dividing into the left and right portal vein branches. The portal vein then drains the splanchnic blood from the stomach, pancreas, spleen, and small intestine, and majority of the colon to the liver before returning to the systemic circulation. The portal vein pressure in an individual with normal physiology is as low as 3 to 5 mmHg. The portal vein is valveless. However, in the setting of portal hypertension, the pressure can be quite high, reaching as high as 20 to 30 mmHg. This results in the decompression of the systemic circulation through the portal cable anastomosis, most commonly via the coronary or the left gastric artery, which then produces esophageal and gastric varices with a high propensity for major hemorrhage. With regards to the hepatic veins, there are actually three: the right, the middle, and the left, that pass obliquely through the liver to drain the blood to the suprahepatic IVC and eventually to the right atrium. The right hepatic vein drains segments 5 through 8. The middle hepatic vein drains segments 4, 5, and 8. And the left hepatic vein drains segments 2 and 3. The caudate lobe is unique because its venous drainage feeds directly into the IVC. The left and middle hepatic veins form the common trunk approximately 95% of the time before it enters the IVC, whereas the right hepatic vein inserts separately in an oblique orientation into the IVC. There is a large inferior accessory right hepatic vein in 15 to 20% of cases that runs in the hepatocaval ligament. This can be a source of torrential bleeding if control of it is lost during a right hepatectomy. For a quick review of liver physiology, the liver is the largest gland in the body and has an extraordinary spectrum of functions. These include processes such as storage, metabolism, production, and secretion. One crucial role is the processing of absorbed nutrients through the metabolism of glucose, lipids, and proteins. The liver maintains glucose concentrations in a normal range over both short and long periods by performing several important roles in carbohydrate metabolism. In the fasting state, the liver ensures sufficient supply of glucose to the central nervous system. The liver can produce glucose by breaking down glycogen through glycogenolysis and de novo synthesis of glucose through gluconeogenesis from non-carbohydrate precursors such as lactate, amino acids, and glycerol. In the postprandial state, excess circulating glucose is removed by glycogen synthesis or glycolysis and lipogenesis. The liver also plays a central role in lipid metabolism through the formation of bile and the production of cholesterols and fatty acids. Protein metabolisms occur in the liver through amino acid deamination, resulting in the production of ammonia as well as the production of a variety of amino acids. In addition to metabolism, the liver also is responsible for the synthesis of most circulating plasma proteins. Among these proteins are albumin, factors for the coagulation system and fibrinolytic systems, and compounds of the complement cascade. Furthermore, the detoxification of many substances through drug metabolism occurs in the liver, as do immunologic responses through many immune cells found in the reticuloendothelial system. Our review on physiology will go a bit deeper on the synthetic functions of the liver, namely the liver function tests. This is a term frequently used to refer to measurement of the levels of a group of serum markers for the evaluation of liver dysfunction. Most commonly, levels of AST, ALT, alkaline phosphatase, GGT, and bilirubin are included in this panel. This term, however, is a misnomer. However, because most of the tests measure not liver function but rather cell damage. Most accurate measurements of the liver synthetic function is provided by serum albumin levels and beer ProTime. Although measuring liver enzymes is important in the assessment of the patient's liver disease, these test results can be nonspecific. Thus, evaluation of the patients with suspected liver disease should always involve careful interpretation of the abnormalities in these liver test results. Albumin synthesis is an important function of the liver and thus can be measured to evaluate the liver synthetic function. The liver produces approximately 10 grams of albumin per day. However, albumin levels are dependent on a number of factors such as your nutrition, renal dysfunction, protein-losing enteropathies, and hormonal disturbances. In addition, the level of albumin is not a marker of acute hepatic dysfunction due to the albumin's long half-life of 15 to 20 days. Most clotting factors, except factor VIII, are synthesized exclusively in the liver, and thus their levels can be used to measure hepatic synthetic function. Measurements of the ProTime and INR are some of the best tests of hepatic synthetic function. ProTime measures the rate of conversion of ProTime to thrombin. Hepatocellular injury of the liver is usually indicated by abnormalities in the level of liver aminotransferases, your AST and ALT. So your AST is found in the liver, cardiac muscle, skeletal, kidney, brain, pancreas, lungs, and red blood cells, and thus is less specific for disorders of the liver. Your ALT is predominantly found in the liver, and thus is more specific for liver disease itself. Hepatocellular injury is the trigger for release of these enzymes into the circulation. So, common causes of elevated aminotransferase levels would include viral hepatitis, alcohol abuse, medication, genetic disorders, and autoimmune diseases. The extent of serum aminotransferase elevations can suggest certain etiologies of the liver injury. However, the levels of enzymes in these tests correlate poorly with the severity of the hepatocellular necrosis because they may not be significantly elevated in conditions of hepatic fibrosis or cirrhosis. So, an example, in alcoholic liver disease, an AST to ALT ratio of more than 2:1 is common. Mild elevations of your transaminase levels can be found in non-alcoholic fatty liver disease or chronic viral hepatitis or infections or medication-induced injuries. For moderate increases in these levels, they can be found in acute viral hepatitis. In conditions of ischemic insults, toxin ingestion, and fulminant hepatitis, AST and ALT levels can be elevated to the thousands. If you remember back in the past or in your earlier years, there are actually two types of bilirubin, your indirect and your direct. So unconjugated and conjugated for short. So if you remember, the indirect ones are actually the ones that are unconjugated, meaning to say that they are not soluble in your blood. So you would consider an elevation in the cases of your intrahepatic cholestasis, hemolytic disorders, or you have your conjugation defects in which that the conjugation process itself is not readily being done upon your bilirubin. However, if there's an increase in your direct bilirubin or the conjugated forms or the one that is dissolved in your blood, an elevation would point to an extrahepatic cholestasis. So, inherited or acquired disorders of your intrahepatic excretion, they are already conjugated in the liver, but the problem is sending them out of the liver. Or you can also actually consider that there's an extrahepatic obstruction, such as your stones or perhaps a tumor. Your alkaline phosphatase is an enzyme with wide tissue distribution and is found primarily in the liver and bones. So, in the liver, this is expressed by the bile duct epithelium. So, conditions that do produce an biliary obstruction, the levels will rise as a result of the increased synthesis and release into the serum. So, the half-life of this is approximately 7 days, and it may take several days for levels to normalize even after resolution of the biliary obstruction. Your GGT is another enzyme found in hepatocytes and is released from the bile duct epithelium. So elevation is an early marker and also a sensitive test for hepatobiliary disease. So like your alk phos elevation, it is also non-specific and can be produced by a variety of disorders and the absence of liver disease. So increases of GGT can be induced by certain medications like also alcohol abuse, pancreatic disease, myocardial infarction, renal failure, and obstructive pulmonary disease. So it is still best that you correlate clinically and then you try to identify, basing on other labs, what the more likely diagnosis is, depending on what your lab results are. With regards to the radiographic evaluation for your liver pathologies, so the first is ultrasound. Abdominal ultrasound is a commonly applied imaging modality used to evaluate for abdominal symptoms. So ultrasonography is a useful initial imaging test for the liver because it is inexpensive, widely available, involves no radiation exposure, and is well tolerated by patients. So it is exactly for diagnosing biliary pathology and focal liver lesions. Liver injury can be evaluated in trauma patients using the focused abdominal sonography for trauma examinations. Limitations would include incomplete imaging of the liver, most often at the dome or beneath the ribs of the surface, and incomplete visualization of lesion boundaries. Moreover, obesity and overlying bowel gas can also interfere with image quality. So, masses usually require further evaluation by other imaging modalities due to the lower sensitivity and specificity of an ultrasound compared with CT and MRI. With regards to your intraoperative ultrasound of the liver, its use has rapidly expanded over the years with the increasing number and complexity of your hepatic resections being performed. So it has the ability to provide the surgeon with real-time accurate information useful for surgical planning and is actually considered the gold standard for detecting liver lesions. It can identify 20 to 30% more lesions than other preoperative imaging modalities. Importantly, it has also been shown to influence surgical management in almost 50% of planned liver resections for malignancies. With your computed tomography or your CT scan, this produces a digitally processed cross-sectional image of the body from a large series of X-ray images. Contrast medium is routinely used in CT evaluation of the liver because of similar densities of most pathologic liver masses and normal hepatic parenchyma. Dual or triple phase bolus of intravenous contrast agent is performed to achieve the greatest enhancement of contrast between normal and pathologic tissues. The radiologist would use the dual supply of the liver and the hemodynamics of the hepatic tumor to achieve this goal. As previously noted, the portal vein will supply approximately 75% of the blood flow, and the hepatic artery has the remaining 25%. However, many liver tumors receive majority of their blood supply from the hepatic artery. After injection of the contrast agent, the rapid scan time of the helical CT allows the CT sections through the liver in both the arterial dominant phase and your venous or portal dominant phase. Respectively, they are the first 20 to 30 seconds after the beginning of the contrast delivery and the one after 60 to 70 seconds after contrast injection. So, thus, in the end, many hepatic tumors that derive the majority of their blood supply from the hepatic artery, as well as other hypervascular lesions, are well delineated in the arterial phase. On the other hand, the portal phase provides the optimal enhancement for the normal liver parenchyma. With your MRI, or your magnetic resonance imaging, this is a technique that produces your images based on magnetic fields and radio waves. So when comparing to the CT scan, the major advantage of your MRI is that it gives you a higher soft tissue contrast resolution and excellent depiction of your fluid containing structures, while at the same time doing away with the ionizing radiation that is inherent with your CT scan. So, as with your iodinated contrast media used in CT scanning, MRI also has its other forms of contrast agents. So, you have your various gadolinium-based compounds. They behave in a manner similar to your iodine, your CT. However, there are newer ones which are more liver-specific MRI contrast agents and has been developed either to rely on the excretion by your Kupffer cells, such as your furomoxide, or on the secretion of your bile by your hepatocytes. And this example includes that gadozectate. Your PET scan or your positron emission tomography is a nuclear medicine test that produces images on metabolic activity in tissues by detecting gamma rays emitted by a radioisotope incorporated into a metabolically active molecule. So, your PET scan offers functional imaging of tissues with high metabolic activity, including most types of metastatic tumors. More than 20% of patients with colorectal cancer initially present with hepatic metastasis, and a large percentage of patients undergoing resection of their primary colorectal cancer eventually experience disease recurrence in the liver. Although hepatic resection of your colorectal metastasis provides survival rates of nearing 50%, the presence of extrahepatic disease is a poor prognosticator and usually precludes aggressive surgical intervention. Although it has still been known that PET scans are still considered a valuable tool for the diagnostic workup in patients with potentially resectable hepatic disease, but still they must be combined with CT to improve an overall diagnostic accuracy. Cirrhosis, the final sequelae of your chronic hepatic insult, is characterized by the presence of fibrosepta throughout the liver, subdividing the parenchyma into hepatocellular nodules. Cirrhosis is the consequence of sustained wound healing in response to chronic liver injury. Approximately 40% are asymptomatic, but progressively deteriorate, leading to the need of liver transplantation or death is typical after the development of your end-stage liver disease. Complications would include progressive hyperbilirubinemia, malnutrition, decreased synthetic function of the liver, coagulopathy, portal hypertension, and hepatic encephalopathy and life-limiting fatigue. Morphologically, cirrhosis can be described as micronodular, macronodular, or mixed. Micronodular cirrhosis is characterized by the thick regular septa, small uniform regeneration nodules, involvement of virtually every hepatic lobule. Macronodular cirrhosis is frequently has the septa and regenerative nodules of varying sizes. The regenerative nodules consist of irregularly sized hepatocytes with large nuclei and cell plates of varying thickness. However, for the third type, mixed cirrhosis is present when regeneration is occurring in the micronodular liver and over time converts to a macronodular pattern. The morphology categorization is limited, and cirrhosis is actually a dynamic process. Cirrhosis can result from a wide range of disease processes, including viral, autoimmune, drug-induced, alcohol-induced, non-alcoholic fatty liver disease or NASH, and metabolic diseases. The clinical history associated with cirrhosis can include fatigue, anorexia, weight loss, jaundice, abdominal pain, peripheral edema, ascites, GI bleeding, and hepatic encephalopathy. On physical exam, a number of findings have been described in patients with cirrhosis, such as hirspidoangiomata and palmar erythema, which are all believed to be caused by alterations of sex hormone metabolism. Finger clubbing may be a consequence of hypoalbuminemia, while the pathogenesis of white nail beds and Dupuytren contractures are less well understood. Males may develop features of feminization such as gynecomastia, loss of chest hair and axillary hair, and testicular atrophy. Splenomegaly is actually common, while your cirrhotic liver may or may not be enlarged. In fact, it may be normal sized or small. Ascites and pleural effusions can be seen with fluid accumulation. Portal hypertension can manifest as caput medusae and or the presence of your Creutzfeldt Baumgarten murmur, a venous hum that can be auscultated in the epigastrium, resulting from collaterals between the portal system and the remnant of the umbilical vein. Jaundice usually does not appear until the bilirubin reaches at least 2 to 3 mg per deciliter. Asterexis can be detected in patients with hepatic encephalopathy. Other manifestations would include your fetor hepaticus, as well as features suggestive of malnutrition such as weakness, weight loss, and temporal muscle wasting. Lab findings vary in the cirrhotic patient depending on the degree of compensation. However, in general, a number of trends are seen. The cirrhotic patient usually has a mild normocytic, normochromic anemia. The white blood cell and platelet counts are reduced, and the bone marrow is macronormoblastic. The ProTime is prolonged and does not respond to vitamin K therapy, and the serum albumin level is depressed. The serum levels of bilirubin transaminases and alkaline phosphatases may all be elevated. Histopathologic examination of the liver tissue is occasionally needed to confirm the diagnosis of cirrhosis and in determining disease etiology, activity, and progression. Liver biopsy can be performed via a percutaneous, transjugular, or laparoscopic approach. If needed, ultrasound or CT guidance can be helpful in obtaining an adequate sample and avoiding other viscera. The Child-Turcotte-Pugh score was originally developed to evaluate the risk of portocaval shunt procedures performed for portal hypertension and subsequently has been shown to be useful in predicting surgical risks of other intra-abdominal operations on cirrhotic patients. Numerous studies have demonstrated overall surgical mortality rates of 10% for patients with Class A, 30% for Class B, and 75 to 80% for those with Class C cirrhosis. The CTB score is derived from 5 variables as shown on the table and is added so and scored accordingly, and then classified as A, B, or C depending on the total accumulated score. In the average adult, 1,000 to 1,500 ml per minute of portal venous blood is supplied to the liver. However, this amount can be significantly increased in the cirrhotic patient. The portal venous system is without valves and drains blood from the spleen, pancreas, gallbladder, and abdominal portions of the alimentary tract into the liver. The normal portal venous pressure is 5 to 10 mmHg. At this pressure, very little blood is shunted from the portal venous system into the systemic circulation. As portal venous pressure increases, however, collateral communications with the systemic circulation dilate, and a large amount of blood may be shunted around the liver and into the systemic circulation. The causes of portal hypertension can be divided into three major groups: pre-sinusoidal, sinusoidal, and post-sinusoidal. In the United States at least, the most common cause of portal hypertension is usually an intrahepatic one, namely cirrhosis. The most significant clinical finding associated with portal hypertension is the development of gastroesophageal varices, which are mainly supplied by the anterior branch of the left gastric or coronary vein. Portal hypertension also results in splenomegaly with enlarged tortuous and even aneurysmal splenic vessels, can result in ascites. The umbilical vein may recannulate and dilate, leading to visible collaterals on the abdominal wall or your caput medusae. Anorectal varices are present in approximately 45% and must be distinguished from hemorrhoids, which do not communicate with the portal system and are not present at increased incidence with patients with portal hypertension. Lastly, you may encounter GI bleeding, particularly from the upper side, from bleeding gastroesophageal varices. And lastly, in terms of diagnosis, the most accurate method of determining portal hypertension is with hepatic venography. The most significant manifestation and leading cause of morbidity and mortality related to portal hypertension is variceal bleeding. 30% of patients with compensated cirrhosis and 60% of patients with decompensated cirrhosis have esophageal varices. Current measures aimed at preventing variceal bleeding include the administration of non-selective beta blockers and prophylactic endoscopic surveillance with variceal band ligation. Endoscopic surveillance with prophylactic band ligation has been associated with a lower incidence of a first variceal bleed. In the event of an acute variceal hemorrhage, patients should be admitted at an ICU for resuscitation and management. Blood resuscitation should be performed and targeted to reach a hemoglobin of at least 8 grams per deciliter. Fresh frozen plasma and platelets can be considered in patients with severe coagulopathy, with the use of short-term prophylactic antibiotics such as your ceftriaxone 1 gram per day intravenously administered has been shown to both decrease the rate of bacterial infections and to increase survival. Vasoactive medications decrease blood flow to the gastroesophageal varices and can be initiated as soon as the diagnosis of a variceal bleeding is made. Although vasopressin is the most potent available vasoconstrictor, its use is limited by its systemic vasoconstrictive effects. Octreotide, however, is a somatostatin analog and has the advantage that it can be administered for 5 days or longer, and it is currently the preferred pharmacological agent for initial management of acute variceal bleeding. Endoscopy with variceal band ligation should be carried out as soon as possible. When medical and endoscopic measures fail to control variceal hemorrhage, balloon tamponade using a sense-taken Blakemore tube will control refractory bleeding in up to 90%. However, this should not exceed more than 36 hours to avoid tissue necrosis. Another option is the use of surgical shunts or your TIPS, transjugular intrahepatic portosystemic shunts. These involve implantation of a metallic stent between the intrahepatic branch of a portal vein and a hepatic vein radicle. The tract is then dilated until a portal pressure gradient of less than 12 mmHg is achieved. However, this procedure is not without complications itself. With regards to the infection of the livers, the first one would be the pyogenic liver abscess. They are the most common liver abscess seen in the United States, may be single or multiple, and more frequently found on the right side of the liver. The abscess cavities may be variable in size, and when multiple, may give a honeycomb appearance. Approximately 40% of abscesses are monomicrobial, an additional 40% are polymicrobial, 20% are culture negative. The most common infecting agents are gram-negative bacteria. E. coli is actually found in two-thirds of cases. For the anaerobic organisms, Bacteroides fragilis also are seen frequently, and in patients with endocarditis and infected indwelling catheters, Staphylococcus and Streptococcus are more commonly found. With regards to the pyogenic liver abscess risk factors, they can usually result from an impaired biliary drainage, subacute bacterial endocarditis, infected indwelling catheters, dental work, or direct extension of the infection such as a diverticulitis or Crohn's disease into the liver. There is also an increasing incidence due to infection by opportunistic organisms among the immunosuppressed. Clinical manifestations of the pyogenic abscess, the patients commonly present with right upper quadrant pain and fever. Jaundice will also occur in up to one-third of the affected patients. In the labs, leukocytosis, an elevated sedimentation rate, and an elevated alkaline phosphatase level are the most common laboratory findings, with blood cultures only revealing approximately 50% of the causative agents. Under imaging, ultrasound examination of the liver reveals pyogenic abscesses as round or oval hypoechoic lesions with well-defined borders and a variable number of internal echoes. On CT scan, it is highly sensitive in the localization of the pyogenic liver abscess, which appear as hypodense with peripheral enhancement and may contain air fluid levels indicating a gas-producing infectious organism. The cornerstones of treatment include correction of the underlying cause and IV antibiotic therapy. Empiric antibiotic therapy should cover gram-negative and anaerobic organisms. Percutaneous needle aspiration and culture of the aspirate might be helpful in guiding the subsequent antibiotic therapy. IV antibiotic therapy should be continued for at least 8 weeks and is expected to be effective in 80 to 90% of patients. It is worthy of knowing that percutaneous drainage catheters is only beneficial in a minority of patients, as most pyogenic abscesses are considered to be quite viscous and catheter drainage is often ineffective. Surgical drainage via either a laparoscopic or an open approach may be necessary if the medical therapy fails. Anatomic surgical resection can be performed in patients with recalcitrant abscesses. The second type of abscess is the amoebic abscess, which is considered as the most common type of liver abscess worldwide. This is caused by the very common Entamoeba histolytica. So, the abscesses formed are variable in size and can be single or multiple. The amoebic abscess is most commonly located in the superior anterior aspect of the right lobe of the liver, near the diaphragm, and has a central portion that is necrotic and contains a thick reddish-brown, pus-like material which has been likened to an anchovy paste or a chocolate sauce. Amoebiasis should be considered in patients who have traveled to an endemic area and presents with right upper quadrant pain, fever, hepatomegaly, and hepatic abscesses. Leukocytosis is common, whereas elevated transaminase levels and jaundice are unusual in amoebic abscesses. The most common biochemical abnormality is a mildly elevated alkaline phosphatase level. Most patients have a positive fluorescent antibody test for Entamoeba histolytica, and test results can remain positive for some time after a clinical cure. Ultrasound and CT scanning of the abdomen are both very sensitive but non-specific for the detection of amoebic abscesses. Usually, they appear on CT scan as a well-defined, low-density round lesion that has enhancements of the wall, somewhat ragged in appearance with a peripheral zone of edema. The central cavity may have septations as well as fluid levels. CT scan is also useful in the detection of an extrahepatic involvement. For the treatment, metronidazole 750 mg 3 times a day for 7 to 10 days is the treatment of choice and is successful in up to 95% of cases. The effervescence usually occurs in the first 3 to 5 days, but the time necessary for the abscess to resolve depends on the initial size at presentation and could vary from 30 to 300 days. Aspiration of the abscess rarely is needed and should be reserved for patients with large abscesses, those who do not respond to medical therapy, or those who appear to be superinfected. Furthermore, abscesses in the left lobe of the liver are at risk for rupture into the pericardium and should be aspirated and drained. Edited disease is due to the infection by the tapeworm Echinococcus granulosus in its larval or cyst stage. Scoliosis contained in the cysts adhere to the small intestine of dogs and become adult tinea. These attach to the intestinal wall, and once they are ejected out via an infected ova containing feces of the dogs, they contaminate the grass and the farmland, and the ova are ingested by the intermediate hosts such as sheep, cattle, pigs, and humans. So the ovum then burrows through the intestinal mucosa and is carried by the portal vein to the liver, where it develops into an adult cyst. Most cysts are caught in the hepatic sinusoids, and therefore 70% of the hydatid cysts form in the liver. A few ova pass through the liver and are held up in the pulmonary capillary bed or enter the systemic circulation, forming cysts in the lungs, spleen, brain, or bones. Hydatid cysts are commonly involved in the right lobe of the liver, usually the anterior inferior or the posterior inferior segments. Occasionally, the affected patients present with symptoms such as dull right upper quadrant pain or abdominal distension. Cysts may become secondarily infected, involve other organs, or even rupture, which leads to an allergic or anaphylactic reaction. The diagnosis of hydatid disease is based on the findings of enzyme-linked immunosorbent assay or ELISA for Echinococcus antigens. Positive results are approximately seen in 85% of infected patients. The ELISA results may also be negative in an infected patient if the cyst has not leaked or does not contain scoliosis, or if the parasite is no longer viable. Eosinophilia is seen in approximately 30% of infected patients. Ultrasonography and CT scanning of the abdomen are both quite sensitive for detecting hydatid cysts. The appearance of the cysts on image depend on the stage of the cyst development. Typically, they look well-defined, hypodense lesions with a distinct wall. Ring-like calcifications of the pericysts are seen in 20 to 30% of cases. As healing occurs, the entire cyst calcifies densely, and a lesion with this appearance is usually dead or inactive. Daughter cysts generally occur in a peripheral location within the main cyst, and are typically slightly hypodense compared to the mother cyst. Unless the cysts are small or the patient is not a suitable candidate for surgical resection, the treatment of hydatid disease is surgically based because of the high risk for secondary infection and rupture. Medical treatment with albendazole relies on drug diffusion through the cyst membrane. For most cysts, surgical resection involving a laparoscopic or open complete cyst removal with installation of a scolicidal agent is preferred and is usually curative. If complete cystectomy is not possible, then formal anatomic liver resection can be undertaken. During the surgical resection, caution must be exercised to avoid rupture of the cyst, which will release the protoscolysis into the peritoneal cavity, and this can result in an acute anaphylactic reaction or peritoneal implantation of the scolysis with daughter cyst formation and inevitable recurrence. Other infections of the liver would involve ascariasis, schistosomiasis, and viral hepatitis, but managements are mainly non-surgical, although in rare circumstances there are some surgical interventions to be done. You may read on them in the chapter, as this won't be covered in the lecture, as we will prioritize more important conditions with surgical applications. So let's move on to the benign lesions of the liver. So, majority of hepatic cysts are asymptomatic. Hepatic cysts are usually identified incidentally and can occur anytime throughout life. The most common benign lesion found in the liver is the congenital or the simple cyst. So, for these cases, the female to male ratio is approximately 4:1. With the exception of a large cyst, simple cysts usually are asymptomatic. Large simple cysts may cause abdominal pain, epigastric fullness, or early satiety. Occasionally, the affected patient presents with an abdominal mass. So, asymptomatic simple cysts are best managed conservatively. So, the preferred treatment for symptomatic cysts are ultrasound or CT-guided percutaneous aspiration followed by a sclerotherapy. This approach has been approximately 90% effective in controlling the symptoms and ablating the cyst cavity. The excised cyst wall is sent for pathologic analysis to exclude the presence of a carcinoma, and the remaining cyst wall must be carefully inspected for evidence of neoplastic change as well. Hemangiomas are the most common solid benign masses that occur in the liver. They consist of large endothelial-lined vascular spaces and represent congenital vascular lesions that contain fibrous tissues and small blood vessels that eventually grow. They are predominantly seen in women and occur in 2 to 20% of the population. Most hemangiomas are discovered incidentally with little clinical consequence. However, large lesions can cause symptoms as a result of compression of adjacent organs or intermittent thrombosis, which in turn can result in further expansion of the lesion. Spontaneous rupture or bleeding is actually rare. The majority of hemangiomas can be diagnosed by liver imaging studies. On biphasic contrast CT scan, large hemangiomas show asymmetrical nodular peripheral enhancement that is isodense with large vessels and exhibit progressive centripetal enhancement fill-in over time. On MRI, hemangiomas are hypointense on T1 weighted images and hyperintense on T2 weighted images. In fact, due to the nature of the hemangiomas, caution must be exercised in ordering for a liver biopsy if the suspected diagnosis is a hemangioma, because there's actually the risk of bleeding from the biopsy site, especially if the lesion is at the edge of the liver. For patients that are actually very symptomatic, or if they opt to do surgical resection, the resection can be accomplished by enucleation or formal hepatic resection, depending on the location and involvement of the intrahepatic vascular structures and hepatic ducts. Hepatic adenomas are benign solid neoplasms of the liver. They are most commonly seen in premenopausal women older than 30 years of age and are typically solitary. Prior or current use of estrogen, particularly oral contraceptives, is a clear risk factor for the development of your liver adenomas, although they can occur even in the absence of oral contraceptive use. Histologically, adenomas lack bile duct glands and Kupffer cells, have no true lobules, and contain hepatocytes that appear congested or vacuolated due to glycogen deposition. Hepatic adenomas carry a significant risk of spontaneous rupture with intraperitoneal bleeding. The clinical presentation may be abdominal pain, and in 10 to 25% of cases, hepatic adenomas present with spontaneous intraperitoneal hemorrhage. To identify these on CT scan, there has been noted that sharply defined borders on the mass and can be confused with metastatic tumors. With venous phase contrast, they can look hypodense or isodense in comparison to the background liver. On arterial phase contrast, subtle hypervascular enhancements often is seen. On MRI, adenomas are hyperintense in T1 weighted images and enhance early after gadolinium injection. For treatment, it is usually surgical, and especially if it comes down to a very large hepatic adenoma, and it is recommended because there is actually a good risk for a transformation, malignant transformation to a well-differentiated hepatocellular carcinoma. Focal nodular hyperplasia is a solid benign lesion of the liver believed to be a hyperplastic response to an anomalous artery. Similar to adenomas, they are more common in women of childbearing age, although the link to a oral contraceptive use is not as clear. Unlike adenomas, FNH lesions usually do not rupture spontaneously and have no risk of malignant transformation. On a good quality biphasic CT scan, this is essentially diagnostic of FNH. It actually shows a well-circumscribed lesion with a typical central scar. They show intense homogeneous enhancement on arterial phase and are often isodense or invisible compared to the background liver on venous phase. On MRI, FNH lesions are hypointense on T1 weighted images and isointense to hyperintense on T2 weighted images. After gadolinium administration, lesions are hyperintense but become isointense on delayed images. The fibrosepta extending from the central scar are also more readily seen in MRI. So, having said that, due to the nature of FNH, the management of it is usually reassurance and prospective observation irrespective of the size. Surgical resection can still be recommended, especially when the patient is symptomatic, or you cannot actually rule out that a hepatocellular carcinoma is there. Also, you might also need to stop your oral contraception as with your FNH, or if a hepatic adenoma was found also. Hepatocellular carcinoma is the fifth most common malignancy worldwide. But however, due to its high fatality rate, it is considered the third most common cause of cancer deaths worldwide. Major risk factors for hepatocellular carcinoma would involve the viral hepatitis, B or C, alcoholic cirrhosis, hemochromatosis, or your non-alcoholic steatohepatitis. So, your liver cancers are typically hypervascular with blood supplied predominantly from the hepatic artery. Clinical manifestations are typically those relating to cirrhosis. So you would have your jaundice, pruritus, hepatosplenomegaly, bleeding, diastasis, cachexia, and the usual from what you've learned earlier. With regards to imaging, on CT scan, your hepatocellular carcinomas, due to its hypervascular nature, will appear hypervascular during the arterial phase. and it will come out relatively hypodense during the delayed phase due to an early washout of the contrast medium by the arterial blood. On MRI, it is also considered an effective way of characterizing your hepatocellular carcinoma. It's kind of variable on T1 weighted images and usually hyper-intense on T2 weighted images. As with contrast CT, the enhancement on arterial phase after gadolinium injection, because of its hypervascularity, becomes hypo-intense in delayed phase due to a contrast washout. Hepatocellular carcinoma has a tendency to invade the portal vein, and the presence of an enhancing portal vein thrombus is highly suggestive of a hepatocellular carcinoma. The treatment options for hepatocellular carcinoma is a bit complex and is best managed by a multidisciplinary liver transplant team. For patients without cirrhosis who develop this cancer, resection is actually the treatment of choice. For people who have cirrhosis but of that of a class A Child-Pugh, resection is actually still considered, yes. If resection is not possible because of a higher Child-Pugh class, it comes to the point that the transplant criteria is going to be used, particularly that of the Milan criteria. And then liver transplantation becomes the treatment of choice. Although chemoembolization may be also some benefit, but these are more of temporizing treatments already. The 5-year survival after complete resection is approximately 30%. Cholangiocarcinoma or bile duct cancer is the second most common primary malignancy of the liver. Cholangiocarcinoma is an adenocarcinoma of the bile ducts. It forms in the biliary epithelial cells and can be subclassified into either a peripheral or an intrahepatic bile duct cancer or a central or extrahepatic bile duct cancer. At first, if you're considering a peripheral or the intrahepatic type, they usually represent a tumor mass within the hepatic lobe or at the periphery of the liver. This is actually less common compared to your extrahepatic bile duct cancer, which can be located distally or proximally in the extrabiliary tree. When proximal, it is referred to a hilar cholangiocarcinoma or a Klatskin tumor. These tumors originate in the wall of the bile duct at the hepatic duct confluence and usually presents with obstructive jaundice rather than an actual liver mass. Hilar cholangiocarcinoma is difficult to diagnose and typically presents as a stricture of the proximal hepatic duct, causing painless jaundice. It preferentially grows along the length of the bile duct, often involving the periductal lymphatics with frequent lymph node metastasis. Surgical resection offers the only chance for a cure for cholangiocarcinoma. In the absence of associated primary sclerosing cholangitis, or PSC, surgical resection is the treatment of choice for hilar cholangiocarcinoma. However, approximately 10% of patients with cholangiocarcinoma has your PSC. This led transplant centers to consider your liver transplant for patients with hilar cholangiocarcinoma. However, high recurrence rates and overall 3-year survival rates are less than 30%. Because the growth of hilar cholangiocarcinoma indicates that this disease spreads in a loco-regional manner, the use of a neoadjuvant chemoradiation was developed and may perhaps have a role in treatment of these types of patients. Intrahepatic cholangiocarcinoma is treated with either resection or liver transplant, but due to the lack of organ donors, this seems to be harder than most. And also the fact that your intrahepatic cholangiocarcinoma is actually rare, the ideal management actually is not yet well defined, but so far these two options are available in the event that you do encounter these types of conditions. Over 50 to 60% of patients diagnosed with colorectal cancer will develop hepatic metastasis during their lifetime. Resection for hepatic metastasis has been a routine part of treatment for these cases. In fact, predictors of poor outcome have already been noted to be node-positive primary, a disease-free interval of less than 12 months, more than one tumor size of more than 5 cm, and a CEA antigen level of more than 200 nanograms per ml. Traditional teaching suggested that hepatic resection for metastatic colorectal cancer to the liver, if technically feasible, should be performed only for fewer than 4 metastases. However, later studies have challenged this paradigm. So nowadays, Resectability is no longer defined by what is actually removed, but indications for hepatic resection now center on what will remain after resection. So, all that, plus the use of neoadjuvant chemotherapy, portal vein embolization, two-stage hepatectomy, simultaneous ablation, and resection of extrahepatic tumor in select patients have actually increased the number of patients eligible for this surgical approach. And with that concludes the first half of this module, also known as your lunch break.